Uh, Good evening, everyone, and welcome to tonight's SWESEM Learnings webinar. For those who are joining us for the first time, you are welcome, and I would just like to briefly explain to you why we created this SWESEM Learnings webinars. The idea actually behind this initiative is simple, but very important for us. We wanted to build a platform where the emergency physicians can engage with the current researchers, discuss clinical practice, and learn from both national and international colleagues and expertise. The Swedish Society for Emergency Medicine Learning Platform is not just about lectures. It's about critical appraisal, reflections, and translating the evidence into everyday emergency care. So our goal is to invite researchers and clinicians who are actively shaping the field of our emergency medicine and to connect their work directly to our clinical reality. So this evening, we have a really great pleasure to introduce our speaker, Dr. Stefano Malinverni, who works at the emergency department of, I'll say it now in French, and Saint-Pierre in Brussels, is one of the leading authors of the recent study from Belgian cardiac arrest registry. So tonight he will present part of his study for us together with other studies comparing the mechanical cardiopulmonary ventilations and the manual bag valve ventilation in non-traumatic out of the hospital cardiac arrest. As we all know that a high quality CPR is the cornerstone of the cardiac arrest management. So however, the optimal ventilation strategy during ongoing resuscitation remain a debate topic, particularly when it comes to mechanical ventilation versus the manual bag ventilation. So by the end of this webinar, we should be able to answer some of those questions, which are, does the ventilation strategy influence the chest compression fraction? Could the mechanical ventilation actually optimize the gas exchange during CPR? Does freeing a team member improving the overall resuscitation performance? Yes, and now I just want to introduce one of our wonderful moderators, Dr. Rasmus Strandmark, to speak about the rules. You're welcome, Dr. Rasmus.
Yeah, thanks. Yeah, so as I briefly mentioned, we usually employ the chat to put in any question that you might have along the way, not to interrupt the speaker just on the talk, and we'll just try to summarize it, and maybe some of those questions will already be answered during the talk, and some might remain. So we'll just talk about that at the end. Please use the chat as much as possible.
Yes. Dr. Stefano, the scene is yours. You can start. And
thank you very much. Thank you very much for the kind invitation. Thank you very much for the introduction. And just want to make sure everybody sees my slides.
Yeah, we do see your slides, and we don't see you, but we've already been through that your video doesn't function already. So you already promised to post a really nice picture of yourself.
No, I will share the slide. This is the most important part. And thank you very much, really, for this invitation. Not sure I will give you answer. Maybe I will just give you more questions, but let's see. Let's walk through this, and let's walk through what ventilation during mechanical or non-mechanical ventilation during cardiac arrest. So I have a conflict of interest that it's important to disclose. I've received research material from Air Liquide medical systems, and this can definitely relate to this talk. So it's important to be aware that I have this conflict of interest. So we are going to speak about cardiopulmonary resuscitation, and as you can clearly hear, there is the pulmonary word in it. As mentioned by Mohammed, we have a lot of emphasis on the cardio part, and maybe there is a new growing emphasis on the pulmonary part of resuscitation. And why is this important? Because at the end of the day, during CPR, what we want is to bring oxygen to two target organs, which are the brain and the heart. So this is what we want to achieve during good CPR. And how can we achieve this? Well, I'm sorry, I have to bring you back to physiology, but the peripheral oxygen delivery, so what you can deliver to your brain and your heart, is the product of cardiac output, which we will see to what we can relate during cardiac arrest, and the oxygen content of your blood. So when we walk this through and we look, okay, cardiac output, what does it look like during cardiac arrest? In theory, stroke volume times heart rate. Okay, heart rate is chest compression rate, let's say, during cardiac arrest. Stroke volume, we don't really have a measure of stroke volume. We measure depth. With a depth between 6 and 5, we are happy. And more or less time CCF, chest compression fraction. The longer we compress the chest during the CPR, the better we produce some cardiac output. And this, as mentioned before, is really the cornerstone of CPR. And this we kind of all agree, and there is a lot of evidence out there saying that we should aim more or less these targets during cardiac arrest. What we tend to, or at least, let's say maybe not we, but I remember myself being taught that, okay, push hard and fast, focused on chest compression fraction, and that's what we have to do. And I remember myself just squeezing the back time to time, and my focus was really on chest compression fraction and quality of chest compressions. But what I tended to forget, and I want to share with you, is that it's not only about pushing blood forward, but it's as well about what you put inside this blood. So this oxygen content inside the blood. And this relates to oxygen saturation and hemoglobin content. Of course, we cannot, maybe one day, but for the moment, it's not the topic. We do not modulate hemoglobin content during cardiac arrest, so the focus is on saturation. And this is important, again, because when you put all this together, you can be excellent in your chest compression part, but if you have no ventilation, so no matter what is the number here, if you multiply times 0, then the result is 0. Okay, of course, I'm exaggerating a little bit. I'm Italian, but it's important to pay attention to the two. And what is complicated is sometimes there is a little bit of conflict between the two. And the other thing is that our attention span is limited. So sometimes when we focus too much on one part of it, maybe chest compression, then we tend to forget and to reduce the quality of ventilation. So you say, yeah, but okay, Stefano, nice, but really, does it really goes that bad? You mentioned this can go to 0. Does it really goes to 0 during CPR? Well, actually, yes. This, of course, are pigs. It's not ethical to do it on humans. But if you stop ventilating one pig during VF and you continue your chest compression, then you see that oxygen saturation quickly, and these are seconds, so maybe in 100 seconds, 120 seconds, reaches almost 0. And something close to 0 here means that 0 times whatever will end up with 0 oxygen delivery to your brain and heart. And even ventilating with just an FiO2 of 17, which is more or less what we expect on exhaled gases when we do mouth-to-mouth breathing, keeps oxygen saturation much higher. So yes, it is important to do at least some ventilation. Okay, at least some ventilation. We saw when we have nothing, we give maybe mouth-to-mouth ventilation, but when we do our ALS, we are taught to give the highest FiO2 available. And is there evidence out there saying that we should ventilate patients with the highest FiO2? Yes, these are experiments again with probes inside the brain measuring PbO2. PbO2 is higher if we ventilate the patients with the highest FiO2 instead of 50% oxygen. So another thing that it's crystal clear, yes, give the highest FiO2. And then you say, yeah, but I'm ventilating with an FiO2 of 1. I'm ventilating as recommended 10 breaths per minute. Do I really have to care about my PaO2? Is there really any hypoxia? Well, yes. When we measure it, it's frequent to have hypoxia. And what is interesting, again, is that the lowest your PaO2, the lower the chances of hospital admissions or CPC, survival with good neurological outcome, as seen here. So the more you increase the PaO2, the better the results in terms of hospital outcome and CPC-1-2. So definitely it is worth to pay attention and to try to increase this term, as it might increase your neurological intact survival. And I focused a lot on oxygen, but it's not only about oxygen. One problem with ventilation, and especially hyperventilation, is that it can induce hypercapnia. And hypercapnia, it's a two-edged sword. So somehow it can be interesting to have a little bit of hypercapnia, as it can vasodilate your brain arteries. But on the other hand, it reduces cardiac contractility and increases pulmonary resistances. So what it is observed in studies is that when you have hypercapnia, it's associated with lower hospital admission. So, okay, it's not clear why. The patient that collapsed with VF, that used to have normal lungs, why suddenly it develops hypoxia and hypercapnia despite we are ventilating the patients, as mentioned, with FiO2 of 1 and 10 breaths per minute. So the answer, I don't know how fireworks looks in Sweden, but in Belgium they tend to look as they look in this picture. And imagine these guys doing 100 to 120 chest compression, 5 centimeters depth on your chest. And I don't know whether any of you simulated chest compression on corpus or Lucas, but it's definitely a very bad experience. So it's something you don't want to do for more than 1 or 2 compressions. So what I want to say is that actually there is a lot of kinetic energy that is transmitted to the thorax of your patients and inevitably to the lungs of your patients. So this is a paper from the group of Magliocca and Ristagno, and they showed that there is some edema that is induced by cardiopulmonary resuscitation, and you have more edema if you're using a chest compression device that is mechanical, so is delivering for sure every time 5.5 centimeters of depth. And the editorial was interesting because it's not really something we can avoid, because it seems like it's the price to pay to get the heart beat. We will need some lung injury because it's inevitable. The way we do chest compression is closed chest compression, and inevitably we will induce some lung edema associated to it. But what is interesting, as I mentioned, is that there is some lung edema that appears through time in chest compression. Another thing, this nice paper from Applied Physiology, another interesting thing is that we lose some lung volume during chest compression. So without ventilation, you see this is the resting volume. What in physiology is called the functional residual capacity. So meaning the lung volume that you have the moment you collapse or the moment there are no forces applied to your thorax. And without ventilation, you see that we tend to lose 350 mLs. If we ventilate the patient with manual bag, we lose a little bit less. And if we put a little bit of PEEP, And then the loss in CRF is furthermore reduced. And why this is important is because when you reduce your pulmonary volume, inevitably you will have some atelectasis that will appear. And when you say atelectasis, there is shunts that goes with atelectasis. And when you say shunts, means gas exchanges disturbances. And this is what we are observing in our cardiac arrest patients during CPR. And then again, I'm sorry, a little bit of physiology, but I think it's important to understand this principle to better understand what we should do during mechanical ventilation. And this is a physiology graph that shows your lung volume here and pulmonary vascular resistances. And nature is pretty well done. So at our functional residual capacity, so our resting point of the lung, we have the least vascular resistances. And if we move our lung towards higher lung volume or lower lung volumes, as we mentioned, what happens during cardiac arrest, then pulmonary vascular resistances increase. And this is very important because imagine all your blood has to go through the lungs. So if you increase pulmonary vascular resistances, then there is an influence and an interaction between your lungs volumes and possibly your cardiac output. Okay, might be a little bit boring, I admit, but still it's a problem that you need to fix, because you have to grant some cardiac output for sure, but you need to make sure that this cardiac output delivers some oxygen to the periphery and especially to the lung and the brain. So, okay, you can't make a presentation on ventilation without mentioning the airway, but I will make really a very short statement, and it's, okay, you have to ensure airway patency. And there's a lot of excellent evidence here. We have 4 randomized controlled trials that says, I mean, this is maybe my synthesis, but ensuring airway patency does not always require the placement of an endotracheal tube, okay, or routine placement of an endotracheal tube. So this is a word on airways. The other thing I wanted to mention before diving more into the subject is that compression-only resuscitation does not grant adequate volumes. So at a certain moment during resuscitation science, some people advocated that, okay, given that we're doing chest compression, at each chest compression, actually, there is some volume that goes in and out of the patient. And this is the small oscillation you see here on this graph. But when we measure this volume, actually, it is something that is close to 40 mLs per chest compression. Okay, you might say that 40 mLs times 100 it's not such a small number, but be careful, because 40 ml, actually you're ventilating only the dead space. It's 27% of the dead space. So it's really fundamentally ventilating the dead space. So passive ventilation from chest compression only will not generate enough tidal volume. So we have to do something active. We have to bring some ventilation to our patient. And I'm here to show you a little bit what was the concept. There was a sort of yin and yang of ventilation. And maybe this is becoming a little bit old as a concept. But we'll start with what was known. What was known, it was that ventilation shouldn't be too little, but probably didn't have to be too much. So the concept was that hypo and hyperventilation were both potentially harmful, okay? And that the best survival was on a sweet point that we didn't know where it was, but somewhere as an inverted U-shaped curve, which is actually very physiological. I mean, every physiological process is either an inverted U curve, either a U curve. So this makes perfectly sense. But let's see in practice. I mean, there is this single paper, and it's almost the only paper that showed that hyperventilation was harmful during cardiopulmonary resuscitation. And why it is? Because they showed that with increasing rates, intrathoracic pressure was going up, right atrial pressure was going up as well. And given that the right atrial pressure is the back pressure of your coronary perfusion pressure, then inevitably, if right atrial pressure was going up, coronary perfusion pressure was going down with hyperventilation. Okay. And of course, you want to have a good coronary perfusion pressure. I mean, there is tons of papers that shows that you should aim a good coronary perfusion pressure, at least above 15. So this was clearly showing that ventilation is harmful. And this ventilation was harmful. I'm not discussing the results. I'm just discussing how they get there. So when you read the paper, you realize that the animals here were ventilated with 30 ml per kg. And I repeat, 30 ml per kg. Nobody would ever ventilate a patient with such a tidal volume, an E per E of 1 to 1, and a respiratory frequency of 30 breath per minute. So, of course, yes, with this crazy tidal volume and crazy ventilation rate, yes, maybe ventilation is harmful, okay? And then there is the other side of the evidence. So when hypoventilation is actually hypoventilation. This paper showed that when you span from 4 to 18 ventilations per minute, increasing the respiratory frequency will increase the chances of neurological intact survivals. And with an odds ratio per ventilation act per minute of almost 4. So this is really interesting. So it seems that going from 4 to 18, there is a constant increase in survival, neurological intact survival. So another, and this is quite some good evidence because it's a randomized study. It's a small study, but randomized, of a respiratory frequency of 20 versus 10 per minute with a fixed tidal volume. Because the fear when you increase, or the concern when you increase respiratory rate, is that mean airway pressure will go up. And again, we will see what we saw in the paper from circulation, that the intrathoracic pressure will go up, the right atrial pressure will go up, and then coronary perfusion pressure will drop. This was a nice paper, and what they showed is that actually mean airway pressure, if you ventilated your patient with 10 breaths per minute or 20 breaths per minute, actually there was no significant difference in mean airway pressure within this range of tidal volume and frequency. And ROSC was fairly identical between the two groups. So when we put these papers again on this graph, what we know, again, 30 times 30, okay, definitely too much. And then, 4 times 6, so 4 acts per minute times 6 ml per kg. Maybe it's not enough. This is on the ascending part of survival. And then when we look at 10 times 6 or 20 times 6, well, to be honest, I don't know where we should put them, but we can say at least that they're one more or less close to the other in terms of survival. At least this is the way I read these papers. And then there is some more evidence. Okay, but maybe, okay, we are ventilating our patients with 6 ml per kg. And finally, why? Because we are extrapolating the data from ARDS to cardiac arrest. And is it really a baby lung at the beginning of the ventilation? Probably not. So maybe we should not blindly follow the evidence that comes from ARDS science, which is, of course, very abundant. So these two papers, one on animal, one on humans, they tried different tidal volumes, so larger tidal volumes. And what they showed is that actually with larger tidal volumes, 13 ml per kg or something like 10 ml per kg, actually you tend to have better PO2, better PCO2, and of course with better PCO2, better pH when you ventilate your patient with larger tidal volume. And this is the important part, without a significant difference on coronary perfusion pressure or cerebral blood flow. Okay, maybe these were small studies. There is large evidence. This is from the group of Seattle. Of course, it's not this is not a randomized controlled trial, but it's a large study. As you can see, it's almost 2,000 out of hospital cardiac arrest. And they did before after study. So they were ventilating with large, normal, let's say, bag mask, and they moved to pediatric sites. It was a decision within their EMS system, and they monitored what they did, which was excellent, and they published their results. And what they saw is that mean ventilation rate didn't change at all during between the before and after part of the study. But what changed was the adjusted odds ratio for ROSC that actually decreased. So this is interesting. Going for smaller tidal volumes was associated with a decrease on return of on ROSC. Sorry, and this was observed as well. It's difficult to say it was a mechanical answer what they gave here, but at least they showed that, minute ventilation was probably reduced in the patients with small bags, because end-tidal CO2 was increased compared to large bag ventilation. There is a lot of confounding factors, but at least they tried to show that minute ventilation was indeed increased in the patients ventilated with the large bags, and that this was associated with increased chance of ROSC. And then this, I think it is the paper that it's giving traction to the ventilation part of CPR. And this is a retrospective paper that has been published on Circulation. And it's quite interesting. So they did a post-hoc analysis on the ROC patients, and they look at impedance, thoracic impedance of these patients, to decide whether the patients was ventilated with less than, more or less, they cannot say it exactly, but more or less 250 mLs per ventilation, or more than 250 mLs per ventilation, which corresponds more or less to less than 3 to 4 mLs, or above, you can't really tell. It's something above 4 ml per kg. So they separated the patients in these two groups. It was patients that were ventilated 30 to 2. And what they decided, it was a decision. They said, okay, we will split in two groups: the ones that have less than 50% of ventilations above 250, or have more than 50% of pauses with ventilation above 250 mLs per breath. And what is striking, and I really think it's only this is it's a super interesting result from this study, is the proportion of patients with small tidal volumes and impossible to detect ventilation in 50% of the access. So it's 40% of the patients were definitely hypoventilated, and 60% of the patients were at least ventilated a little bit. We don't know exactly how much, but something that we can consider acceptable. So hypoventilation in excellent conditions, because I mean, this is a post-hoc analysis of the ROC trial, which is a randomized controlled trial with a lot of efforts on and a lot of emphasis on chest compression. So it was really well-trained teams performing this resuscitation. And even in these excellent conditions, we observe hypoventilation in 40% of the patients. And this is quite striking. So it should question our practice as well, what we do in our hospitals and in our ambulance. And then, the results striking again, and 2.1 of neurological intact survival in patients that are hypoventilated, and 5.1% in patients that are at least ventilated a little bit. We don't know exactly how much, and this is quite a big difference. And what they showed as well, and this is quite interesting, is that there is a continuum. Okay, so they showed for 4 outcomes, which is ROSC, hospital admission, survival, or neurological intact survival. They showed that the more ventilation were detected through the CPR, the higher were the chances of ROSC, the higher were the chances of admissions. And where it comes really interesting, I think, is this hyperbolic curve of survival and this exponential curve of neurological intact survival. So it seems that the more we ventilate the patient, the better it is the neurological intact survival of this patient, because there doesn't seem to be a plateau here in this curve. So, of course, a lot of limitation. It's thoracic impedance. It's not, they didn't exactly measure ventilation. It was an indirect measure, and as well a retrospective design, but still this is, I think, strong evidence showing that actually what we do on our daily basis is probably not as good as we think, because 40% of the patients are really hypoventilated, and that if we improve this ventilation, maybe we can improve the survival of our patients. So again, putting this all together, when you have small volumes, even if you have good frequencies, most probably you are on the ascending part of the survival curve for your ventilation. So a word on PEEP, why it matters, why it is dangerous. Again, a yin and yang of PEEP. So PEEP, most people are reluctant to use PEEP during cardiac arrest, because they say, as you see in this curve, they say, if you increase PEEP, this can decrease cardiac output. Okay, this is really basic physiology. There is a slight increase with PEEP of oxygen content, but which is not compensated by the decrease of cardiac output. So the result of the equation is that oxygen delivery decreases with increasing PEEP. And this is totally true. And if you look, and I really like this image, whenever PEEP is above central venous pressure, then preload is decreased on your right atrium. Okay, but this is interesting during cardiac arrest, because actually during cardiac arrest, CVP increases a lot, actually, because pressures tend to equalize between the arterial and the venous side. Of course, with chest compression, you produce a cardiac output and you reduce the central venous pressure. But inevitably, in any patients during cardiac arrest, CVP will increase compared to whenever he was alive. So having a PEEP of 5, most probably during cardiac arrest, will not be above CVP and will not probably reduce the preload of your heart. And again, what is the effect on FRC? So we saw before that during chest compression, FRC, so the functional the volume of your lung at rest will be reduced. And by reducing the volume of your lung, pulmonary vascular resistance will increase, which might affect actually your cardiac output. And this is shown in this figure. Just the fact of placing your Lucas on the chest of your patient will reduce the lung volume from the FRC. So what PEEP can do in this case, it can tend to restore your FRC and increase a little bit your lung volume, reducing therefore pulmonary vascular resistance. And when this is very theoretical, but it's physiology. And when we test this in animals, in pigs, so here you have cardiac output and here you have oxygen delivery. So in cardiac arrest, we see this effect of decreasing cardiac output with high level of PEEP. So 10, 15, 20, but no difference between 0 and 5 PEEP in terms of cardiac output. And what you observe is that there is a slight increase, non-significant, in the oxygen delivery of your patient or animal if you put a little bit of PEEP. So maybe a little bit of PEEP is not so deleterious during cardiac arrest because there is no transmission from the alveoli to the right atrium, and because CVP is increased in these patients. So current guidelines. Before there was no much emphasis on ventilation at all. And now with 2025 ERC guidelines, there is some emphasis on optimizing mask sealing and airway permeability and to increase this sealing with a 2-person technique if necessary. Okay, and this is very important because most of the time, if you do it alone, having a good sealing is very difficult. So you squeeze some air from the bag, but you do not push it inside your patient. You just squeeze it in the room. So is our practice consistent with guidelines? As I showed you with the paper from Circulation, most probably no. And just to have one more image to show, in theory, 1 minute of CPR according to guidelines is, 30 chest compression, 2 ventilation, 30 chest compression, 2 other ventilation with a steady tidal volumes. Or if you're doing asynchronous, again, you have a ventilation every 6 seconds, always with the same tidal volume. But this is the theory. And actually, when you look at practice, what we do probably is something more like this. I try to squeeze, it doesn't work. Then I push harder, it's a large volume. And then I tend to get distracted. I push 2 small volumes. Or when I have intubated my patient and I'm using a bag, sometimes I'm stressed. I have a higher ventilation rate, and sometimes I squeeze more, sometimes less. It's not very regular and difficult to have a steady ventilation when doing manually. And that's why I think in 2025, the ERC introduced mechanical ventilation during chest compression, because it can introduce some reproducibility and some, at least, help us to stick to the guidelines and to what is recommended. And what they do recommend is volume controlled ventilation with a tidal volume going from 6 to 8 of predicted body weight, as we may said, FiO2 maximal, a ventilation frequency of 10, a PEEP which can goes from 0 to 5. And this is very important because if you start to do mechanical ventilation tomorrow on your ventilation in your ICU or in your ambulance, and you don't have a cardiac arrest mode, what you will have to do definitely is to change the pressure alarm and the flow trigger. Because if you don't do that, if you don't take the flow trigger off, then each chest compression will be detected each chest decompression will be detected as an inspiratory effort, and then you will have your patient that will end up breathing at 100 breaths per minute. And if you don't change the peak pressure alarm, then at each chest compression, the alarm will detect an increased peak pressure and will stop the breath. So these two modifications have to be done before you start to use your ventilator during cardiac arrest. And it's not so easy. So we'll come to it maybe afterwards. That's why maybe it's nice to have a dedicated mode on your ventilator for cardiac arrest. So after the paper on circulation, this editorial, they said, okay, we can only improve what we measure. And actually what we did during 20 years was measuring chest compression, depth, frequency, release, chest compression fraction. And this helped a lot to increase the compression quality and the survival of our patients. And actually is what this is a Zoll monitor, is what you see here on your Zoll monitor. And now what should be done, and what I think should be done, and not only me, but other people, is that not only you should focus on the quality of your chest compression, but actually on the quality of your ventilation as well, both in terms of tidal volumes and of rate. So there are different devices. Some here I don't have a conflict of interest, and I think some better than the other. The ArcDO Life has the advantage that actually measure expiratory tidal volume, which is much more interesting than inspiratory tidal volume. And we'll see why, because there is a lot of leaks. So actually you should focus definitely more on expiratory tidal volume when you measure ventilation. And does it work? Again, a small before-after study, a lot of confundants, but survival goes up when you start to measure ventilation and try to improve the quality of your ventilation. So, and I mean, this we can discuss the quality of this study a lot, maybe, but we cannot discuss the fact that if we want to improve something, we have to measure it. I mean, this is true and has been said many times. So yeah, now it brings us to the core of the discussion, is like to bag or not to bag. Okay, manual versus mechanical ventilation. Why mechanical? And really making it super easy. Why mechanical? Yeah, it grants you a good compliance with the prescription. What you tell the machine to do, the machine will do it exactly as you said it. Then we'll see it's not a perfect compliance because there are still some problems, but at least a good compliance with what you prescribe. Manual is cheaper, is widely available, and is the current standard. So it's always difficult to change from the current standard. And actually, it's not only about the resistance to change. What I want to say as well is that you have to have good evidence to move from something that is the current standards to something else. So actually, most probably, maybe for the moment, we don't have that evidence or enough evidence to make this change. So two example of dedicated mode, which and this here, I mean, it's another company, so really no conflict of interest. I really advocate for, because if you just push a button and then you have a prescription with all these alarms of peak pressure or the flow trigger that is off, I mean, it will really help you during your cardiac arrest. If you have to start to manipulate, change the alarms, change the flow trigger, I mean, it gets pretty complicated, and maybe it will dilute all the benefit of mechanical ventilation. And both Hamilton or and Key, they have just one button. You push the button and then it starts. Okay, we'll see there are some differences between the two modes. So one thing is that important is that I had this discussion with Aurora Maglioca, and she says, yeah, when I put the ventilator, I'm sure that actually I'm delivering this tidal volume. Well, just careful. You're not 100% sure. What this study shows us is that with supraglottic airway, actually there is a mean leak of 42%. And 42% is not trivial. I mean, it's a lot of leak. So if you're using a supraglottic airway and you just look at the inspiratory volume that you're pushing inside your patient, I mean, you might be 42% wrong. When you use tracheal intubation, then, okay, the leak becomes more trivial. 5% of leak is completely acceptable. And then, yeah, inspiratory volumes tend to be much more similar to expiratory volumes. So just this point of attention is not because you're using mechanical ventilation that you're actually 100% sure that you are delivering what you prescribed. What I think, and this is what we're trying to demonstrate here in Brussels at the moment, is that there is a cognitive burden. At the beginning, and actually during the first 6 minutes of your CPR, there is a lot of things that you have to do and you have to pay attention to. And you just have maybe 2, 4, maybe 6 hands, but still it's not enough, okay? And there's a lot of cognitive burden to get all these things done in the right order. So I think that here mechanical ventilation can help by taking some of this cognitive burden, and you just drop this burden on the machine and the machine does it right for you. This is just an abstract, so it's not a published article from us, but I wanted to show you the results. And what we found is that when we use, and this our result is a single center study, yeah? So external validity is very questionable. But what we saw in our center is that when we use mechanical ventilation, chest compression fraction increases. And the reason, I mean, the mechanistic explanation I have for this is that we can focus on something else. We do not have to focus on ventilation. We have less cognitive burden. We can concentrate on keeping the patient on good chest compression. And what we saw as well, and this is interesting, but has to be proven on a larger scale, is that untidal CO2 increases as well, suggesting probably that this increased chest compression fraction translates into an increased cardiac output of the patient. So now for the very end, not very end, but almost, the specific ventilation modes for CPR. When you're using a Hamilton T1, or when you're using your balloon, what happens during chest compression is that some air will leave the chest. And of course, here's the graph is a bit overinflated because we saw that the volumes are small of air going in and out. It's most probably 40 mLs, but still you have this movement. I push the chest, I want to squeeze the heart, but actually I'm squeezing the heart and the lung, which means that actually my cardiac output, is a bit diluted, reduced, because part of my chest compression are actually squeezing the lungs and not only the heart. And during chest decompression, what happens is that air enters the lungs. What I would want to have is just blood entering the heart. So during chest decompression, I really want just the heart to be filled. But given that actually I'm releasing the compression on the thoracic cage, which has both the heart and the lung inside, we have both blood and air entering the patient. So it's this is what it is with normal ventilation if you use a Hamilton or if you use a bag. And this is CCSV mode. Some modes, what they will do is that they will synchronize an inflation with your chest compression. And the rationale of this is that actually your heart will be squeezed both by your lungs and by your chest compression, which will result, in theory, hasn't been proved, to some more cardiac output. And the other way around, during decompression, pressure will drop as well in the respiratory circuit, allowing a heart filling that will be increased. So this is the theory behind the CCSV mode. And does it work? Seems like there are not much paper outside, but when you look at arterial and venous pressure during CCSV, and when you move to a more conventional way of ventilating your patient, you see that there is a pressure drop moving from CCSV to EPPV. This is one single paper, so it's maybe a bit early to draw a conclusion, but still there is some evidence out there. There are as well some evidence on patients from CCSV showing that PCO2 might be slightly better, not significant, but significant only in terms of pH, but not on PCO2, but slightly better in CCSV compared to bag ventilation during cardiac arrest. And in the same study, what is interesting is, the mechanistic part on gas exchanges, but as well on heart outcome, there is a trend, what the Spanish group showed, there is a trend toward higher survival, neurological intact survival in patients ventilated with this mode comparing to the bag. And in between the two, EPPV, is normal volume controlled ventilation. Another paper from the German Registry. It's a bit complicated methodology, and maybe for a sake of time, I will skip. But what they showed is that there was a significant increase in ROSC rate, higher than expected, when ventilated the patient with EPPV, which I would say basically is mechanical ventilation in its most basic mode. BPAP was the one associated with the higher rate of ROSC. So there is something going on in mechanical ventilation here. Another specific mode for CPR is CPV, the one from Air Liquide. And why I like it, and again, I have a conflict of interest here, but we chose the ventilator before getting funded. So the way I really like this mode of ventilation is that it's a pressure mode. It makes much more sense for me to ventilate the patients in pressure rather than volume, because one pressure might more or less fits all at the beginning, but volumes you have to adapt to the size of the patients by definition at the beginning. What the ventilator says, it cuts all the alarm. It gives you some feedback on chest compression fraction because it can detect the chest compression, and gives you the feedback, which is most important, on the expiratory tidal volume. So no alarm, it starts with a beep of 20 of inspiratory pressure and 5 of PEEP with 100% of VO2, and does something, conceptually similarly to CCSV, but with, not so intense as a CCSV in terms of modulating the flow during chest compression, meaning that during chest compression, the expiratory valve is slightly closed, which makes a brakes to the exit of air. And during decompression, actually there is no PEEP, so the pressure can reach 0. So there is a modulation of the entry and exit of air during each chest compression, which to me makes sense in theory. As I told you, the spiring valve is partially closed during chest compression and PEEP only during compressions. So this was the paper we did on the Belgian registry. It was a retrospective study, so observational. What we found in the registry, we compared patients ventilated with the normal bag, no PEEP, and unknown respiratory frequency, to patients ventilated with the CPV mode, so meaning an inspiratory pressure of 20, PEEP of 5, and a respiratory frequency of 10. What we found is that there were some raw differences between the two groups, with actually better ROSC in the mechanical ventilated patients. And when adjusting for confounding factors such as age, sex, shockable rhythm, no flow, and low flow, then we ended up with an adjusted of ratio of 2, meaning actually that CPV, when adjusting for these confounding factors, doubles the chances of ROSC. Why it works? Is it compliance with guidance? Is it PEEP? Is it chest compression quality, as I showed you that CCF increased? I don't know. It was a purely observational trial, so it is impossible to disentangle what drove the results. And now this brings us to the end of the presentation. Sorry if I took a little bit maybe more time. So what we want for our patient is some tailor-made ventilation. We want the perfect PEEP for our patient with the perfect tidal volume and the perfect respiratory rate. So this is what we want for our patient. And we spoke about FRC, and it seems that when you think about it, it's important to place your resting lung volume close to the FRC. Why? Because if you go below the FRC, imagine your lungs are squeezed, your thorax is squeezed, your airway are squeezed. Okay? So having the lung squeezed means that actually gas exchanges will be affected. There will be some shunt. As we saw, there is an increase in vascular resistances, and it will induce airway closing. And another thing, when you squeeze too much your lung, then you tend to have rib fractures. Having a rib fracture, maybe a single one, is not catastrophic, but imagine if you have multiple rib fractures, then you change the elastance and the recoil of your lung, which becomes completely problematic, because this is what helps you to generate the cardiac output. So you would like to have an ideal compromise, having your lung at your resting volumes at the FRC. And what you don't want to ventilate above the FRC, because again, you will have a hyperinflated lung, which now, if we really increase the intrathoracic pressure, it will drive a reduction in venous return and increase vascular resistances. Again, because as I showed you, it's a U curve. So you want this ideal compromise. Okay, but how to get there? Because you cannot really, experimentally, you can measure the FRC, but you cannot measure the FRC during chest compression. What this paper showed is that maybe we can use the capnograms to identify where we are in terms of FRC. So they identified 3 patterns of capnograms, which might help us. One pattern is this constantly increasing CO2, which makes end-tidal CO2 interesting to interpret. But this is another discussion, whether you should use end-tidal CO2 or not in this case. But when you have this increasing pattern of CO2, then you might suppose that you are in an airway closure system and that you're ventilating your patient below the FRC. What you want to see is this constantly oscillating pattern with a constant reduction. You see there is a trend toward a reduction of CO2. And why this? Because actually at each compression, you're ventilating the dead space. So by ventilating the dead space, CO2 actually goes down. Another pattern that you don't want to see is that one of thoracic distension with this initial increase in CO2. And then after you gave a couple of compression and there is a loss of volume in your lung, only after a couple of compression, you have this oscillating pattern that appears. So this maybe, and has to be reproduced, can help us on the field to individualize PEEP and tidal volume or pressure, depending how you're ventilating your patient during CPR. So my last slide, my conclusions. So high quality ventilation improves the outcome. You need a respiratory rate of 10 or above, but quite surely below 30. Tidal volume could be something between 8 to 12. We need a lot of more evidence to decide which is the exact tidal volume. PEEP, you can safely place a PEEP between 3 and 8 centimeters of water without affecting the cardiac output of your patient. And what you really want to avoid is hypoventilation. You should avoid hypoventilation much more than hyperventilation during CPR. Mechanical ventilation during CPR might help, reducing your cognitive burden and delivering the exact volumes that you want to deliver. And always, 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 always measure ventilation, especially the expiratory tidal volume. And last, and this is really when you want to be advanced, maybe capnograms might help to individualize ventilation during CPR. Thank you very much for your attention.
Okay, brilliant. Thank you so much. That was answered all my questions. So I'm sort of like the last few minutes I've been sitting here. What am I going to ask? Because as you went along, you really sort of addressed everything. I was especially interested in LMAs versus intubation, endotracheal intubation, whether or not that would sort of be enough for mechanical ventilation. But with the leakage there, as you explained, that might be the case. Any comments on that other than the leakage, Stefano?
So between supraglottic device and tracheal intubation, this is your question.
Yeah, exactly. In terms of using the mechanical ventilation option in LMA or endotracheal tube.
I mean, I think, and this is really opinion, so big disclosure. I have no evidence supporting this, but I think that all of us, we have a bit, there is this ongoing confusion between the airway and ventilation. And maybe the two things can evolve separately. So I think again, that we have come to a quite good level of evidence on how to manage airway. And what I understood from the evidence is that it's a stepwise approach. So when I arrived, I don't have the material, I just use my mask. I can quickly put maybe a supraglottic device. And then afterwards, after some times when I can do it in the proper conditions without affecting the chest compression, I place my tube. So this, I think we can more or less all agree on that. But this is our way. And so our way will do is path through resuscitation independently of mechanical or manual ventilation. Why that? Because actually, and this is maybe our experience, and maybe this was not clear, or I didn't present this part of the results, we tend to use mechanical ventilation from the very beginning. So we arrive on the scene, and we know we are arriving on a cardiac arrest. we lit the mechanical ventilator in the ambulance. So when we arrive, actually, everything is ready. We just take out the tube from the mask, and we place our circuit on the mask. And you can actually deliver mechanical ventilation through non-invasively through a mask. And I don't have hard evidence because we only have retrospective data, but I can tell you that what we do tends at least retrospectively to increase survival compared to manual ventilation. So what I wanted to say is that at least it's not harmful. At least I'm not sure whether I can say it can improve survival, but it's not harmful. So I'm sorry, I took a lot of time to answer your question, but I think that the two things can be separated. The two discussions can be separated. Airway and ventilation are two different topics that, of course, are interrelated, but you can have mechanical ventilation without having an invasive airway. Of course, with the limitation of a non-invasive airway. Of course, it goes with these limitations.
Yeah, and I think, Jonas, in terms of PEEP, that goes with the same. As long as you control leakage, then I suppose you could accept PEEP with both bags, as we regularly do, and with LMAs.
Yeah, the transmission of your pressure will be more exact, going in a stepwise evolution from mask to supraglottic to endotracheal tube. Of course, you'll be much more precise, and what you put as a PEEP, it will be the PEEP in the alveoli of your patients. If you have an endotracheal tube, you're not completely sure, or pretty not sure, if you do it to a mask.
Yeah, I'm really happy that we also now acquired new ventilators with this specific mode, because that's really helpful, just to be able to push that button and get that setting from the start. Any other questions? There's nothing else really in the chat. Anything from Mohammed
I
or
have
Tobias?
just some comments. I really liked Stefano's slides about the hyper and the hypoventilation. I just want to comment about a phenomena, if you all know about it, it's called Lazarus phenomena, which is really rare phenomena, like when you do CPR to some patients and then they would declare their death, and just when you remove everything, they get alive. And I really read about it because we had actually one case in our hospital in Uppsala for about 2 or 3 months ago about it. And I really read about it as well. And one of the hypotheses also is because of hyperventilations, that you trap the air in the lung, and when you do CPR, you will not getting ROSC because of the increased intrathoracic pressure. And when you remove everything, so you will get ROSC because of the pressure in the chest decrease.
Yeah, indeed. And I have one question then. Was your patient known for COPD or asthma? Because this often, if not always, appears in patients which have increased airway resistances. And then, yes, of course, you should individualize your ventilation, but as you would do it in an alive patient, leaving enough time for the air to leave the chest of your patient.
That's really good. I need to ask my colleague because he had the case.
Stefano, I have a long question because I remember when people started to use or systems started to use the mechanical chest compression devices. Everyone was very happy, and they had some quite clear evidence for some benefits, and especially theoretically, they had some evidence or some benefits. But now, when more evidence are showing up that it's not actually increasing ROSC, and it's not increasing neurological survivals after cardiac arrest, do you think that this mechanical ventilation system is kind of the same. We have a theoretical idea that this should improve ROSCA and survivals, or do you think this is just a new tool for us to use?
Yeah, I get your question, and I really understand. I mean, I'm a emergency physician, so I understand this, euphoria of a new, yeah, tool or technological device that you can add on your resuscitation. It always sounds cool. I understand this part of the dilemma, and really the story from the Lucas or I mean mechanical chest compression taught us a lot on maybe compliance with the recommendation does not always increase survival. But the story of mechanical chest compression is interesting because there is a high price that you have to pay to get your chest compression, mechanical chest compression going. I mean, I don't know whether you measure your time to place the Lucas. I don't know whether you have Lucas or Corpus CPR or Autoputs, but whatever. I mean, when you see it in the videos, it's always super easy. Okay, 5 seconds and the device is running. And we train every morning. Every morning we do a simulated session to place, we have Corpus CPR. And actually our best field result is 12 seconds. But this is the best field result. I mean, meaning that sometimes we have like maybe 30, 40 seconds to get the machine running because we measure a lot of things that we do during our resuscitation. And if we do the parallelism with mechanical ventilation, when I arrive and I have to place my mechanical ventilator, it doesn't affect at all there is almost, I would say, there is no price to pay in terms of degradation of the quality of the CPR to get the mechanical ventilation going. So I think that it's one difference that worth to be mentioned, between having mechanical chest compression going and having mechanical ventilation. And the other part of the answer, sorry, you made a long question, so I'm taking a long answer, is that maybe one thing I would not advocate for is to have a fixed tidal volume for everyone. Because this is exactly, I think, what maybe it's part of the mistake or mistake. Can you call it a mistake? But it's part of the reason why we don't see an increase in survival with mechanical chest compression, because you cannot have one size that fits all. So you look much taller than me. So maybe for you, 5.5 centimeters of depth, it's good. It's probably good. But for me, I'm 1.65 meters. So maybe for me, 4.5 is the best. Depth. And if you have one guy that is 2 meters, maybe you need 6 centimeters. And another thing is chest compliance. When you put the Lucas or the Corpus CPR, no matter what the chest compliance is, they will go for 5.5 centimeters. And again, if we do the parallelism with mechanical ventilation, if you put 500 ml for everyone, this is no matter what the compliance of the lung is. I think it's much more interesting to start with a pressure mode. So at least you put a constant pressure, but you're not having higher pressure than what you would want, at least. So I'm sorry, it's a bit long and complicated, but I think the problem is long and complicated.
I think so too, and I think so many things of this, everything in cardiac arrest and everything in the compliance to the guidelines and everything, you aim to a system that is one size fits all, and what we are actually discussing here is to tailor everything individually, and I think that that's actually a complete, I mean, not a shift from the guidelines, but it's a step away from the guidelines actually, because I guess that's what we should aim for as an emergency physician society and a society of resuscitationists or whatever we could call ourselves. That we actually should provide that extra benefit for the system, for the patient, and then you need to use the tools that you can tailor. And if you don't have the machine, you don't have the system in place that you can understand and make that work. I mean, that's you can just, what I'm just trying to say in a very strange way is you need so many things for this to happen, and I think it's great, and I think it's what we should aim for. But it's also you can't just put it on. The machine doesn't think for you. The machine doesn't do everything for you. As I have seen myself with the mechanical chest compression machines, that you can't just put them on and everything is good. So you need the system to use the machine in. That's a weird way. Thank you very much. It's a long discussion, and how to build systems to provide this tailored cardiac arrest. And I think we should invite you to that discussion further on.
But just to make it much more simple, maybe I think it's an opinion, again, big disclaimer, very little evidence to say that, but and we have to be very cautious. But what we saw from the paper on circulation is that actually ventilation quality is very poor. So I'm not advocating for, maybe the most important message of my presentation is I'm not an advocate for mechanical ventilation. What I advocate for is to measure your ventilation, really. And this is the most important message, is because you can't improve what you can't measure. And this is a mantra that, I mean, we all have in our systems. So measure something, and then once you measure it, try to improve it. Can be with mechanical devices, can be with a tool as simple as the EOLife. This is an excellent tool.
All right. I think there's no further questions in the chat box. If any one of the participants have something interesting to discuss, everyone that wants to stay on, obviously, are more than welcome to. I myself am going to log out now. I thank you for an extremely interesting presentation, Stefano. It was a real pleasure listening to this, and it gave me some really good insights that I didn't know about, and that I'm definitely going to take with me into clinical practice on the next shift. So thank you so much.
Thank you very much for the invitation. Really was my pleasure, and to share my field of interest.
Exactly. Thank you very much, Stefano. And it was really, really interesting session for us, because as you mentioned before, like all the cardiac arrest practice and training is mainly focused on the circulation, and they don't put too much like effort on the ventilation. So it's a really good point to take with us. And I would like to hear from you more like in the future. So I hope to see you again soon as well with us.
Thank you. Thank you very much, guys. Thank you for the invitation.
You're welcome.
Thank you very much, Stefano.
For all guys, if you want to keep in touch, or if you have any further questions with Stefano, so he found in LinkedIn, and just write his name and you'll find him, and continue discuss things with him. Thank you. Have a nice evening, everybody.
Good night.
Take care. Bye.
Thank you. Bye-bye.
Bye.